Hello everyone, welcome to Medica Cardio Talk episode 25, and I'm excited again. I'm joined by two of my colleagues. One is Dr. Ashesh Haldar and Dr. Debopriyo Mondal, and we recently had ACC 2024 where very thought-provoking and practice-changing many multiple trials were presented, and we are going to pick and choose only 4 trials which we see a huge importance to all of us, and it's a very difficult and arduous task, but we are going to do that. And to begin with, physiology, entire physiology driven coronary revascularization, this concept has taken a back seat in this AC 2024. They have got a double blow in form of full Revas trial as well as prevent trial. So we are going to discuss those trials. And coming to TAVI, dedicated TAVI trial, this is an additional very robust non-industry driven data and evidence in favor of transcatheter aortic valve replacement. And finally, there is some good results for cardiogenic shock patients on mechanical circulatory support. Impella has given some positive results. So now coming to Dr. Ashesh Haldar, how do you feel? Is ischemia driven revascularization and this entire physiological concept is going to take a back seat? Please tell us and enlighten us about full Revas trial and what you feel is the possible implication of this trial in future.
So thank you, sir, for the question. That is a very interesting trial, and in the full Revas trial, the FFR guided revascularization of the non-culprit vessel in patients with STEMI were tested and compared with the standard therapy on OMT group. So in full Revas trial, the patients who were selected had STEMI who underwent primary PCI, or a high risk in STEMI group, or patients with rescue PCI, or in patients who had underwent risk stratification after thrombolysis. So the non-culprit vessel which were amenable for PCI were selected, those who had FFR positive of less than 0.8. It has been seen at the end of 4.8 years, the FFR positive value in patients who had FFR positive, they underwent angioplasty, and at the end of 4.8 years, in respect to primary endpoint of MI or CV death or unplanned revascularization, was quite similar as compared to the OMT group. So, but as well as in respect to secondary outpoint, the CV death as well as the MI was not different as compared to the OMT, and unplanned revascularization was quite similar. So that was a result of this trial. But interesting to note, in patient who had a stenosis of 90 to 99%, they had FFR negative in 20% cases. Those who had stenosis of 70 to 90%, they had 50% FFR negative, and who had 50 to 70% stenosis, they had 70% FFR negative. So I think
I think you very rightly presented that. So what do you feel? The angiographic correlation with FFR was not very robust here. Yeah. And second, the controlled arm where they analyzed standard of care patients where they did not go for non-culprit vessel revascularization, and they did it in in future if the patient needed it. So what do you feel like? It was just in against the trial was complete shock trial which came. This trial gave a different verdict.
Yeah, surely this trial did give to us a different verdict, because in complete trial that was not powered enough to see the response of the trial. But in complete trial, more than 70% visually stenosed patient who underwent angioplasty, they did show a great result in response to primary outcome. There's a significant benefit as compared to the medical therapy. But this is in contrast to the full Revas trial, which did not show any great benefit.
Great.
This is again in addition to the FIRE study. Yeah. In FFR positive, revascularization was shown to be beneficial in patients who had an age of more than 75 years. So this is in contrast.
So I think it's the entire field is really getting very exciting.
Yes.
So we have 2 trials on each side. We have got this full Revas trial, and in addition we have a flower MI trial again. Yes. That too showed not much of benefit. And we have 2 randomized controlled trials which are positive. So we are at equipoise, and I don't know what is going to happen in future. So basically this is what operator feel is also very important.
Yes, sir.
And patient circumstance and hemodynamics stability and situation is very important. Now let me throw some light on prevent trial. So it's indeed a very thought-provoking trial. So anatomy getting more precedence on physiology. So Debopriyo, can you tell us about prevent trial and what message it gives us?
So good morning, sir. Good morning, everyone. It's been the second time here we are talking and discussing about the recent trials and talking about prevent trial. Why this trial has picked up motion is because till now the most data came from FFR and probably from IFR and recent times RFR also, but the most robust data has come up from FFR. Now, like beyond 5 years or 6 years back, there was a class 2B recommendation for IVUS in cases of borderline lesions. In prevent trial, what they did was they picked up lesions which are borderline or intermediate, and they did it to prevent cardiac events, let's say target vessel revascularization or non-fatal MI or cardiovascular events. And they chose the lesions based on physiological parameter, the anatomical imaging parameters. So basically what they did was they chose 2 out of 4 criteria. So the 2 out of 4 criteria will be based on either IVUS or OCT imaging, and the recent most research tool till now which is not available with us, that is the near infrared spectroscopy, which gives us an idea about something called LCBI. Now if I say 2 out of 4, what I mean is we have a MLA which is less than 4 square millimeter. We have something called total plaque burden which is more than 70%. Then we have something called the TCFA, TICPA or thin cap fibroathyroma, and LCBI, lipid core burden index of more than 315. So if we have 2 out of 4 positive, and if these lesions were revascularized, they found out over a period of 2 to 7 years that there was a significant difference in patients who are kept on standard optimal medical therapy versus who are guided against these imaging modalities. And there was a statistically significant difference of around 15 to 20%, wherein these patients who were image guided revascularization was done, they had shown a positive impact. So the importance of the trial, what I feel, sir, is we should give enough importance to OCT or IVUS in deciding the lesions and then going forward with the revascularization.
So till now there is no guideline which endorses imaging as a tool and criteria for going after a lesion.
Yes.
So this is the first such trial which has given us a hint, and this trial showed mainly positive results in target vessel revascularization, ischemia revascularization, TVI, but the mortality were not different at 2 years as well as 7 years. So what do you feel like if a patient has 50% more than 50% disease and stable angina, you have kept medical therapy, in 7 years they might have progressed, the disease might progress and you may need a revascularization. So is it going to give us any extra value because total mortality was not same? So
sir, I think we should get back to the famous editorial in JACC, that is the myth of the vulnerable plaque. So in that editorial also we keep on discussing about the vulnerable plaque, but the myth lies in the statement that we should again go in details about the composition of the plaque. If it is a more atheromatous plaque, if the TCFA is less than 35 to the tune of 10 or 15, then they are more vulnerable. It is not like all plaques are vulnerable and we should keep on doing that. And I think here the importance of imaging comes into play.
That's right. So but still it's just a hypothesis generating trial, if I may say so. So now coming to one of the important trial, again dedicate our trial, and this is the first randomized controlled trial which is non-industry driven, and it has given a very, very good result. So can you tell us something about dedicate trial, the kind of how it was designed and what was the results?
Yes, sir. So that is a wonderful trial. We have seen partner 1, 2, 3, Notion, and with a comparison of TAVI versus SAVR in several risk group population. Now this is the first time we are seeing a trial which is non-industry driven, which is investigator initiated trial, which compared TAVI as compared to the SAVR in patients with severe aortic stenosis But one thing is important here, and they excluded patients who had a bicuspid aortic valve or severe LV systolic dysfunction.
So they were all low risk patients.
Yes, low to
intermediate to low risk,
patients.
and they were truly from tower side aspect also they were low risk patients.
Yes.
This is the beauty of the trial.
Yes.
So many trials they say low surgical risk patients, low intermediate to low surgical risk patients, but tower risk can be even more. Low coronary, bicuspid aortic valve, then this, from tower side becomes high risk. So this trial compared low risk and intermediate risk intermediate surgical risk patient versus low intermediate, we may say so, tower risk patients. Yes.
So at the end of 1 year, they actually looked for whether TAVI is non-inferior to the SAVR in respect to primary outcome, which was mortality and stroke, and they saw a non-inferior result. But in respect to TAVI is superior as compared to the SAVR in several secondary endpoints, like there was reduction of the atrial fibrillation or bleeding complication, reduction of the all-cause mortality, or there is a less chance of stroke who underwent TAVI as compared to the patient who underwent SAVR.
So very, very robust reduction in fact, total mortality, disabling strokes, onset of atrial fibrillation, and they're hugely different. And it gives us a very kind of reassurance in this therapy. So TAVI, an expanding pool of population of intermediate to low risk, surgical intermediate to low risk patients, TAVI is a wonderful therapy and can match and even be superior to surgical aortic valve replacements.
And the mortality rates also, if we might say, the standard STS database mortality for single AVR is around 3.5%. And in this low risk TAVR also it is similar, it is not higher than that.
Yeah.
So we are giving them less of risk and probably getting better.
And they use 61% balloon expandable.
Yes. So we have seen the results of Notion also. There's a
So
lot.
how did they choose the valves? So it was on operator discretion.
It was actually operator discretion, but they use, as you rightly said, 61%. They used a balloon expandable valve.
Yeah. So now finally coming to some real good results for any MCS in cardiogenic shock. So Danger Shock trial has given us a ray of hope. Can you explain? Dr. Debopriyo.
So Danger Shock trial was basically a trial which tried Impella CP, specifically a device in patients who are in cardiogenic shock. And till now we have all the data from worldwide. We have data from PGI Chandigarh also for all comers who presented with cardiogenic shock, that if we are doing revascularization only without any support, till the mortality is more than 50%. Whatever we do, the mortality is still more than 50% who are in class 4 or cardiogenic shock. So this trial actually selected patients who had MI who were in cardiogenic shock, and the Impella CP device was put inside the heart just to maintain the hemodynamic support during the procedure as a pre or in the interval period. And it was seen that it was a statistically significant difference in the outcomes. Can you, sir, tell us about the outcomes of this trial which was found, sir?
Yeah, so total mortality was around 48% in Impella group and 58% in standard of care group. So, and this was very, very, intrigued that those patients who were given Impella and also for standard of care patients, after the time of randomization, the Impella which were put in were only 15 minutes.
Okay.
And from symptom onset to randomization was 4.5 hours. So, do you feel this is reproducible in general population and general practice at this moment?
Sir, I think it is actually very difficult that we have to be. We in our hospital, we are practicing the door to balloon time. We are strictly abiding in that rule, but to get into that forum or arena, it is.
So and also the bleeding risk and complication risk like limb ischemia and all were pretty high. It's something which was significantly high in Impella group. So at this moment, I think this is a good trial which has shown first time any MCS positive trial in cardiogenic shock patients, but is it reproducible, number one, and can we adopt it just as the face value of this trial? So these are two burning questions. Which
I feel in very selected population we can use
and the operator has to be mature, they have to be experienced in reproducing these kind of results. So I think it was a wonderful discussion. Thanks Dr. Ashesh and Dr. Debopriyo. And I hope it was useful for all of you, and we are going to come back again, episode 26, Medica Cardio Talks, and we'll be bringing up more and more trials and data and some new new information. Thank you so much.
Thank you.
Thank you.